Now we have two parallel panel discussions. In Audi 1, there is a public sector panel discussion on building India's health infrastructure, Atmanirbhar Swasth Bharat Yojana to develop capacities of public health system. This will be moderated by T. Radhakrishna, editor, South, etgovernment.com. In Audi 2, there will be an enterprise panel discussion on the role of next-gen technologies in healthcare. Where are we? This will be moderated by Dr. Rabbani Tariq, digital health advocator. Over to you, Radhakrishna and Dr. Tariq.
Hi, ladies and gentlemen. Welcome to Innovation and Intelligent Healthcare Virtual Summit and panel discussion, Building India's Health Infrastructure, Atmanirbhar Swasth Bharat Yojana to develop capacities of public health systems. In the panel discussion, I am joined by Mr. Purushottam Kaushik. Mr. Purushottam Kaushik, Head India World Economic Forum, and Dr. K Madan Gopal, Senior Consultant, Health, NITI Aayog. Mr. Niraj Kumar Bansod, Director, Health Services, Department of Health and Family Welfare, Government of Chhattisgarh. Sir, welcome to the panel discussion. My first question to Mr. Purushottam Kaushik. Health is a state subject matter. However, central government plays an enabling role with its ministries such as Health, Family Welfare, Ayush, and Pharmaceuticals. How significant the World Economic Forum, India's role in health in India, if you could highlight, please.
Thank you, Mr. Radhakrishna, for inviting me. It's really a good opportunity for us to showcase or at least tell us about our efforts that we have been working in the health sector. So we had initiated a exercise along with the Health Ministry, NHA, and Ministry of Electronics and IT also, and NITI Aayog as well. We went deeper into the subjects, and that was not something which we went specifically around COVID, but then that was an overall effort looking at the disease burden of the country. And then what is the role that emerging technologies can play across, which would mean technologies like AI, IoT, drones, data policy, and blockchain, because these are really transformative technologies which can really drive some of the challenges that we are facing on the resources side in the health sector. So we have been working and evolved a strategy across this ecosystem. We shortlisted about 18 odd themes, and these themes are running across preventive, curative, and governance. And our focus has been that how can we build a collaborative model? We can call it public-private collaboration, where industries, startups, and government can work together and can really produce the results and outcomes which possibly could not have been possible when you're working in silos. So it's pretty much that kind of effort that we are working. And our focus moving ahead will be to go theme by theme and then go deeper into looking at wherever the gaps are and identifying those areas of intervention which can be done with the help of technologies and then put them into pilots. So that's the effort that we are working on along with the state governments and also with the central government ministries. Telangana is one state which we have been working very closely, but then so is our effort towards other states as well, like Karnataka and Maharashtra as well.
Sir, my first question to you is, sir, health is a state subject matter. However, the central government plays an enabling role with its ministries such as Health and Family Welfare, Ayush, and Pharmaceuticals, and its ecosystem. What is the key mandate of NITI Aayog in health, if you can highlight, please?
This is very interesting and pertinent question, given the circumstances that what role NITI Aayog is envisaging, and it has been envisaged to do as for the implementation of the program, because health is the state subject and the ministry is there, and what is our role, what is the role envisaged by NITI Aayog. You recall the meeting when the NITI Aayog started in 2017. There was a meeting, and it was agreed that we need to work in the spirit of cooperative and competitive federalism. With that motto, we are just pushing and working with the states We are bringing out, apart from that, NITI is spearheading the uh, SDG indicator achievement in the country. So we are doing that. To achieve that, not many initiatives have been pushed by NITI Aayog. One of the important activity which NITI Aayog has pushed is the aspirational district program. So, having said this, if you look at the indicator-wise performance in SDGs, the Sustainable Development Goals, you find that there are few districts. Unless these districts come up with the other districts, we are not going to make a dent into this SDG indicators. So as a result, what happened, instead of previously we used to have a backward district program, we had high burden districts, then we told the district requiring support. Instead of saying and coining this kind of term, we came up with a term called aspirational district program. Means the district aspire to be sitting with the normal districts, which is with a good indicator. That's one initiative which has been received across all the ministries, because we are not the implementer, but here in the spirit of competition, we are competing with the ministries. Certain districts we are mentoring, certain districts Ministry of Health is mentoring, and certain district Ministry of Home Affairs is mentoring, and certain districts is given to education and other things. So that collectively we are seeing that the SDG indicators and the other indicators of these districts are improved. Apart from that, we usually provide an oversight to the different programs of the ministries of Ayush, the pharmaceutical. We have seen, you name any program, the NITI presence is there. Right from the launch of the Ayushman Bharat program, where NITI was also instrumental along with the Ministry of Health, wherein the comprehensive program was rolled out as the Ayushman Bharat Health and Wellness Centers. And the other was labeled as a Ayushman Bharat PMJ program. So both these pillars were there. This is a major thing which has been pushed. Another major thing which NITI has achieved during this year was the abolition of the Medical Council of India and the commissioning of this National Medical Commission. It's a major thing which has the fruits of this would be visible in the coming years. Because there were certain issues with the baggages and other issues with the as well MCI. Now all the things have been started new with the National Medical Commission. You will be seeing how quickly things have taking a new shape and how things are moving in that direction. That's another aspect. And because it's a very tricky question, what NITI is envisaging when this. Another thing is after that collective meeting with the chief ministers of all the states, it was agreed that we should be monitoring the health, water, and the education very sector closely, because these are very important and they can affect the lives of people. So as a result, in the spirit of competitive federalism, so we have bringing out a state index, health index. We are in the process of the round 4 of the state health index. We have been talking about data-driven governance, but this is the actuality how the data can drive the governance. First round, the first round happened during 17-18, and that was not much traction was there. After the round 2, we could at least push that to be included in the innovation funding of NHM. And as a result, a lot of traction is there on this state health index, and it is pushing the states for achieving. So in this kind of ways, we are trying to see that how we balance. State is a state subject, state is doing that thing. And apart from that, ministries, most of the states nowadays for health related activities, they are dependent on NHM funds. That's a major funding which is happening through NHM. So as a result, if some innovation devolution is linked to our index, that it is prompting the states to look at the data very carefully, meaningfully, and see that if it is indicators are not moving, what can be done. If the indicators are moving in a positive direction, what best these people they have done. So that kind of efforts which we are making. Side by side, we are into the pharma. We are trying to see that how the Ayush can be mainstream. They had already been mainstream since 2005, but we are seeing that how more mainstreaming of Ayush can also happen. How the existing systems can be built into this, so that a citizen is given a choice of choosing between any pathies. It's not a mixing of it. It's a choice given to the people so that they can choose it from whatever thing in an institution where all the things are co-located. That kind of vision we are trying to push in the Ayush. And the pharmaceuticals also, you have seen that the production link incentive scheme during the COVID time, and in the even the vaccine development also. So if you look at the empowered committees and the National Expert Group on Vaccine Administration, the NITI is represented in all the represented means. In fact, it is either the convener or either the chair of all this. That means it is trying to see that how the different actors they are glued with our efforts and other things.
So considering that vaccination is a top priority for all the states for its citizens to give it 18 to 44 and above 45 age, what has been your priorities on the ground today, sir?
The state of Chhattisgarh is actually looking forward, and there is this strategy of Government of India's strategy that test, treat, track, vaccinate, and follow COVID appropriate behavior. So we are actually following the same strategy, and we so far state of Chhattisgarh has vaccinated more than crore population, and we stand among top states in the entire country when it comes to vaccination. So vaccination is the highest priority of the state of Chhattisgarh.
What is the indent, total indent that you have in place and you have proposed to the Government of India to get the number of vaccinations?
As such, we almost whatever we indent to Government of India is generally the current situation is that since the demand is there all across the country, what the Government of India does is they generally allot us a stock of, let us say, a week or so. So normally at any given point of time, we are consuming a stock of, let us say, 2 lakhs to 3 lakhs per day sort of vaccine. So this is our consumption, and based upon the consumption, we, even if whatever amount of indent we generate and we send to Government of India, we generally get what is the vaccination rate that is there in the state of Chhattisgarh. So as such, the indent is comparatively high, but when it comes down to the vaccination rate, and accordingly, Government of India gives the.
If I may ask you, which are your ongoing initiatives with whether it is the Government of India or state governments? If you can briefly elaborate.
Sure. So we, as I said, we had shortlisted some 18 themes, and these themes were running across 3 core areas. We picked up cancer in the month of April as looking at much deeper. We formed a core community or a team which was consisting of leading oncologists from various hospitals like Tata Memorial, Lilavati, Rahecha. And then we also looked at some of the healthcare institutions like Apollo, as well as some of the not-for-profit and maybe implementation agencies on the ground. We also have the tech organizations like AWS, Microsoft, IBM, as well as Dell, working very closely on these projects. And many of these organizations, if you may know, like PHFI, etc., have been working on the ground on a through significantly maybe expanded effort across the states. And what we did is that we pulled in all their common understanding of what the sector brings as possibly an opportunity for technologies to really perform. And now we have looked at identification of some of the big gaps that exist, including the resource gap and data availability of data, which has been one of the biggest limitation with regard to launching any new initiatives. And also we consulted quite a few startups in leading startups who possibly are looking at cancer as a very specific subject. So between these industry and startup ecosystem players, we are now evolving an approach which could possibly take a view which may have a few, I would say, sectors. One is focusing on the gaps. Second is looking at the technologies innovation which can be solving those gaps. And third is the structure of public-private collaboration which could be done on as in pilots on the ground. And by middle of August, we should be forming up this approach. Likely scenario, we have received a lot of intent from both the healthcare institutions as well as the technology organizations and few startups to launch a few pilots on the ground. So then subsequently what we will be doing is that looking at putting these frameworks and policies proposals to be piloted on ground, run it over a period of maybe few months, or maybe it may take some more time, measure the impact, and then bring all the evidence-based learnings back into the structure of implementation frameworks. We are having some extended discussions in the month of August with the NHA and with a few other ministries as well. And then looking at how can we possibly look at building up something which is more collaborative than actually two sides doing their own stuff. So it's pretty much an effort to bring the ecosystems together, and then looking at some of these subjects which possibly need that kind of deliberation much deeper. And then obviously looking at the tech ecosystem, which is how these technology organizations can work very closely with startup institutions, but then not necessarily they only focus on technologies as in technologies, but then make the technologies work for the real gaps which we have discovered during this exercise. So it's that kind of work which we are doing. But subsequently, there are 17 more themes which we are going to be picking up now. And there are discussions which have already started, say diabetes, and we are looking at maternal health care as well as a few other immunization programs. So some of these issues are already being worked in. Besides this program, there is also an initiative which we are working on drones. The project that we are running on is Medicine from the Sky, which is basically leveraging drones for delivery of vaccines in remote places to begin with. But then we are also looking at other issues, other things which need to be delivered at those places where possibly the roads are inaccessible, or maybe sometimes the situation becomes so critical that you need to kind of rush either the blood or maybe organs or some other challenges which happen around the health. That's the project which is right now, which we're working with the NITI Aayog as well as with Ministry of Civil Aviation and Telangana state very closely. Arunachal, which is also another state, which is northeastern zone, which possibly needs some of those deliberations, especially the northeast as well as maybe some of the inaccessible hilly regions where possibly population is in remote places and lives are lost because of medicines and because of blood not being accessible. So these are the two, I would say, big initiatives which we are working on ground with regard to health, leveraging emerging technologies.
Thank you, sir. Sir, being India's think tank, you bring out a lot of blueprints and publications in health subject. Some examples: Vision 2035, public health surveillance in India, investment opportunities in India's healthcare sector, and some of the ongoing are report on health insurance for India's missing middle population, increasing access to hospitals in Tier 2, Tier 3 in India. I mean, I'm sure these are the very significant initiatives, but I just want to know how these documents and approach suggestions will align with the national policies and state policies in making the India's health sector robust and economically affordable and accessible for all, sir.
This is a very interesting question. If you look at the evolution of our National Digital Health Mission, you see that the document which we have prepared, initially when the rollout of PMJ was supposed to happen, so software was selected, one software of a state was selected, and we thought that we should be having a stack. So NITI came up with the idea, NITI along with the Ministry of Health and Family Welfare, we came up with an idea of having a national health stack, so that all the program data coming from different programs, if you would be surprised that you name any program, they are having their own website and other things. So we thought that we should be having a stack where all the data is reposited, and with a common identifier, we can access all the data at a common thing. With that thought, the National Health Stack was there. So having got an impetus in that direction, so after the National Stack, so the work started towards developing a National Digital Blueprint. So National Digital Blueprint was also finalized, and for implementing the National Digital Blueprint, which have been prepared with the NITI as an important partner. So for implementation, that National Digital Health Mission is there. Now you have seen that how it has been implemented, and we are there in the governing board as well for guiding the implementation process also. So in that way, whatever documents we are preparing, we see that it is translated. Similarly, you talk about the vision document for 2030 surveillance. We haven't, if you look at the current pandemic, if you look at the Western world, or particularly the states, we are having a single agency, that is CDC, which takes all the charts, it takes all the calls for public health. But we have multiple agencies here. We talk about the genomic surveillance. NCDC is doing the genomic surveillance. DBT is also through its laboratory is doing it. ICMR is also involved in that, and CSR laboratories are there. So in that vision document, we have also propagated that we should be having One Health. In the coming years, as the travel and other things also increases, the interaction of man with animals and the vegetation also increases. So we have to not restrict ourselves to human being surveillance. We have to do the surveillance for the animals. We have to see that how the plant and other things when it comes to contact with human beings. So One Health approach has been envisaged in that, and we are more or less moving in that direction. And our role is to glue all these people and make a common platform so that the synergies and other things happen. If you look at the current pandemic also, we are acting as the glue for all the various organizations so that everybody comes on the same platform and things are in a common, things are moving in a direction in which a common objective is achieved.
Sir, you also hold Chief Executive Officer of Ayushman Bharat, the national scheme. So, as you know that, sir, national portability is built part of the Ayushman Bharat program and scheme. And how do you see that aligning with Chhattisgarh Ayushman Bharat scheme compared to the, total overall national scheme, sir?
You see, Chhattisgarh has it is one of the pioneer states when it comes to the health financing scheme. Chhattisgarh started this working in this sector since 2009, since the days of Rashtriya Swasth Bima Yojana. Now, currently, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is converged with the state Dr. Khubchand Baghel Swasth Sahayata Yojana. So we call call this scheme as Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, Dr. Khubchand Baghel Swasth Sahayata Yojana. So we operate this scheme into trust mode, and earlier we used to operate 4 to 5 different schemes. There was different CM sponsored scheme, and there were a separate scheme for the APL families, and so a lot of other schemes. There was a special scheme for heart related disorders, and then eye related disorders. So all those schemes were actually merged, and with the single IT platform of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, that is known as TMS. And there are some other platforms like hospital empowerment platform, health benefit package platforms. So all these IT platforms are now being used, and we have converged all these schemes integrated into one scheme, and we are operating the scheme. And this is one of the important innovative convergence which has taken place in Chhattisgarh, and which was actually appreciated by National Health Agency, Ayushman Bharat.
Thank you, sir. So telemedicine has been given top priority ever since COVID, the pandemic, what we are witnessing today. In terms of usage of telemedicine, maybe e-Sanjeevani or one of your any in-house applications, what has been Chhattisgarh's experience in dealing with or using the telemedicine concept?
Indeed, telemedicine has come up as a very great support when it comes to the patients who were home isolated. We used telemedicine as one of the important tools to monitor these patients regularly. Not only e-Sanjeevani, but the government of Chhattisgarh had its own local this thing by which we actually connected the ANMs and methanins and all other grassroots workers. Apart from that, we had a network of doctors who joined voluntarily, and the state one solutions and all. So we used these solutions of telemedicine in order to actually treat these home isolation patients. And let me tell you, so far Chhattisgarh has treated more than 90,000 persons in home isolation. So telemedicine has definitely benefited a lot, and we are now actually we are expanding this telemedicine through e-Sanjeevani, health wellness centers, and other diagnostics also.
Sir, if I may ask you, on the ground, what are the challenges that present your state is facing, and how do you finding solutions to mitigate these challenges?
The current challenges which we are facing is that definitely one of the biggest challenges is the human resource. The second wave of COVID, when it hit Chhattisgarh, like any other states, Chhattisgarh had all the problems, but definitely the important challenge was to cope up with the actually capacity, with the skilled manpower. We had ventilators, but there was a problem in the skilled HR to operate the ventilators. There was a problem in skilled HR to operate the oxygenated beds, and so on and so forth. So these things are there. So I think one of the biggest challenges is the human resource, because let me tell you, the infrastructure, the equipments, the oxygen plants and oxygen beds, there was no issue with that. But yes, Chhattisgarh somehow coped up with in the state disaster relief funds. We had generated HR, like 3,000 special HR were recruited through SDRF to bridge the gap of the HR. But nevertheless, it was one of the biggest challenges.
Being a reputed global organization, and do you see that any potential of best practices outside India, bringing to the health subject in India and aligning that with the national policy and state health blueprints? Is there any opportunity like that?
So for sure, there is a huge convergence which can be brought in between on the policies and also on the frameworks which are being tested by private ecosystem, but mostly beyond government convergence. So we have been that has been our motto, that most of the programs, the way we structure it is that we have the government community also a part of these discussions. So we start with like having some kind of a structured engagement with the ministry or with the state governments, and we ask them to join those meetings and working groups, so that whatever we evolve is not basically becomes a representation towards the ministry, but also becomes like a evolved framework and approach done along with the government itself. So most of this approach has been very successful. We have in the recent past specific work on health, and also with regard to the drones work which we are doing. What we have done is that we have been evolving the approach with regard to policies and programs which can be done on implementation. The other thing which we are also looking at leveraging is that there are a lot of field organizations from the government side, like in the case of health, it could be healthcare workers, or maybe even some of the programs which are on children and maternal healthcare, Anganwadi workers. Practically all the possible field extension resource we need to possibly find a way to converge and leverage. So that has been our focus, that instead of just kind of looking at industry and maybe possibly the startup ecosystem trying to kind of do their own small bit, how can they become a part of the government-led field programs? Second thing is that there are a lot of programs and policies which has government budgets behind it. Now, for the same approach, if they can converge and mix or maybe include the role of technology as well, the impact will be much more wider. And we have seen that already through so many ecosystem programs which are already in running. And third one, which we are also very, very keen about, is the role of data. Now, how can we look at data being biggest enabler for any innovations to happen, and not necessarily remain in a kind of a closed environment? The other thing is most of the data which is also getting collected is not really in a digitized form, or is not really usable for any further innovation like AI. So our effort has been on big time on how do you kind of enable data for the larger innovation to get unlocked. So for sure, data, programs and policies, and the field institutions to converge is what I would say the bigger agenda for us to look at adoption of emerging technologies.
Telangana state and Karnataka state and some southern states have used drones to transport the vaccination from one location to another location in order to, since they are not able to go to that place by the road. So do you see any possibility like in Chhattisgarh, in future you are using some kind of a sampling or piloting using drones?
I really can't say about it because there are no doubt so many inaccessible areas in Chhattisgarh, especially the southern area which is actually LW affected area. There is a lot of forested and tribal area which is very inaccessible and difficult to reach, hard to reach areas are there. We have a strong network of methanins who are known as ASHA workers. We have 70,000 strong methanins. Then we have, definitely there may be a scope, but as far as Chhattisgarh is considered, I don't think so. In the immediate near times, it will be it can be thought of.
Sir, have the healthcare services in government hospitals been stabilized for COVID and non-COVID today, as on today?
Yes, yes. See, our state has the current positivity is less than 1. It is mostly, and it is hovering around 0.5, 0.6. We have opened up the non-COVID services, the cataract surgeries, the planned elective surgeries have started happening, taking place, and the child healthcare services, they were actually suffering, maternal health services were suffering. So all these healthcare services are things are back on platform. No doubt because of the COVID, the infrastructure has also improved. The bed capacity has improved. The ICU capacity, the oxygenated beds capacity, which are otherwise also required when it comes to the critical healthcare services delivery. So the things have improved, and currently the COVID and non-COVID healthcare services both are going on simultaneously. And this will probably, even if there is a third wave, this will go on.
To enhance the impetus for healthcare infrastructure in the state, many state governments have enhanced their budgets and also come out with some kind of infrastructure growth plan for health infrastructure in the states. In terms of your state, what are the ongoing plans for the health infrastructure enhancement in your states for current financial year, sir?
We have a network of district hospital, medical college hospitals, and we have a network of civil hospitals and community health centers. All these facilities are relatively bigger facilities when it comes to other centers like PSCs or the sub-health centers and health wellness centers. The government of Chhattisgarh is planning to have a oxygen plan for the entire state. We are actually planning to have a liquid oxygen tank and PSA plant in every district hospitals, every medical colleges. Then every CSC will be having 50% of oxygenated beds, and there will be at least 2 to 3 beds in every CSCs, which will be ICU beds with ventilator. PSCs will also have some oxygenated beds, and for this we are going to invest funds through state budget, through the districts. With their own funds, they're also going to raise this infrastructure. So we are ramping our healthcare infrastructure, especially looking into the so-called third wave, which is, if at all it is there. So we are pushing our healthcare infrastructure.
Sir, my final question to you, sir. To strengthen the health infrastructure in the country, a new central scheme called Prime Minister Atmanirbhar Swasth Bharat Yojana announced in the recent budget with an outlay of the 64,000 plus crores over 6 years. I'm sure this scheme will be focused on developing primary, secondary, tertiary healthcare systems, strengthening existing and future new institutions for detection and the cure of the new diseases. I just want to check with you, what are your ongoing priorities in the health sector as a think tank at current financial year?
There are many priorities in the health sector. One is because the lessons which the COVID has taught us, that means we should be having a very robust surveillance system. And if you have seen the Atmanirbhar Swasth Bharat Yojana, a major impetus is given on the development of the public health laboratories, the isolation wards at the block level, as well as the infrastructure support. That's one area which they would be doing it. The other challenge which is there is the data sharing, because you see that how a crowdsourced initiative like COVID.org and the other this John Hopkins University, other people, they have come up beautifully, and that that have been able to at least generate some intelligence, and it has given some insights.
Okay.
Shortly, that would be an area, because we have to work on that so that data is made available on a real-time basis, so that the researchers and other people, based on certain protocols and the policy of the government, they can be able to use that data to generate some intelligence and at least share their views on that kind of data which is generated. That's the second thing. Third is in this COVID times also, with a bigger health resources, we have been able to manage this. That's an area where a lot of focus is to be given. Third, and the other thing is the regulation, because we don't have the regulatory capacity to regulate. We have a lot of regulations, but we don't have the capacity to do regulations. Regarding the HR also, you see that we had innovation and we take pride in saying that we have managed the patients on home. But this is the reality. That means what we are talking, if our systems are working, you see when the systems got overwhelmed during the COVID times, the patients who were supposed to be treated in ICU, they were shifted to the oxygen supported beds, and the patients who were supposed to be managed in institutions where oxygen support is required, they were pushed down to the home and they have to be managed there. As a result, new innovations came. But it's a reflection. That means we have to invest there as well to see that in case of future pandemics or future this kind of epidemics happen, we should be prepared for that. So that kind of things are another. Lastly, we have to see that how we use the technology, especially the telemedicine. It has become a fashion to talk about telemedicine, e-surgery, everything. But do we have a 24/7 this telemedicine platform? Do we have a specialist kind of telemedicine platform? That means a lot of aggregation and networking has to happen so that we provide good quality telemedicine services. But nowadays, we are only talking about the provision of the telemedicine, how much we have reached, how many calls are there. What about the quality of that services? What about the standard of consultation which we are doing on telemedicine? Is it leading the person or linking that person to any institution? It just stops there. If you look at the telemedicines which have been provided during this COVID times, so what we have seen, the telemedicine, everything has happened. The moment the patient saturation comes down, he has been referred to the hospital and the patient has to fend for himself. That kind of loop, we have to see that how it is completed. That kind of standard methods we have to evolve in the telemedicine also. So lot of things have to be done. Lastly, the capacities of the people, right from the doctors to the lower staff, it is an ongoing continuous process, and we have to use technology and other measures so that the continuous education of this staff and other things is put into place and being used.
Doctor, one quick feedback from you. Did NITI Aayog give any suggestion to government on the telemedicine practices? It should be 24/7.
If you look at when the COVID started, when the lockdown was there, and people were stuck up, and most of the hospitals were closed for non-COVID patients.
Absolutely.
At that time, when our member was there, so he was the chairperson of Board of Governors, which was managing MCI. And at that time, when these guidelines, there were no guidelines, and doing teleconsultations and giving prescription by telephone was not legal as per because many of the honorable courts, they have taken cognizance of that. They have even taken action against the doctors who was prescribing.
Yeah.
So to enable that, at that time, NITI along with the MCI, we have pushed for this guidelines, and the guidelines are made on this. Now we are trying to see that how these guidelines are implemented. Now, as you are saying that 24/7, how it can be made, we are already been floating this idea to the other stakeholders. We are trying to see that how there is a traction among the different players, because majority of the players are in private sector. How to make a network of this thing, who will come forward, who will be the aggregator, and what kind of services they will be providing, what kind of MOUs they will be having with each other. So that kind of thing is still in work. It's going on. It's a work in progress.
Yeah, my final question to you, in the union budget for 21-22, the government of India announced Atmanirbhar Swasth Bharat Yojana to develop capacities of the primary, secondary, tertiary healthcare systems in the country, essentially to strengthen existing national institutions and create new institutions to cater to detection and cure of new and emerging diseases. Do you see that, any role that you play, or any your observations or views on that?
For sure. See, the health infrastructure will always, when we look at the actual gaps in the scenario, obviously infrastructure is limited, and we have realized it during the COVID times as well, that when things really go wrong, infra becomes like challenging. And good part also is that compared to other countries, we have had a system which possibly goes much deeper into the roots. And the only thing was that this time the capacity testing was possibly more challenging than what it was designed. However, from the perspective of looking at how can the gaps in a longer term, where the demand can be as unpredictable as we have seen, we possibly need to build infra which can be meeting up those flexible requirements and flexible demands. For example, like if you're talking of maybe cancer, as in like the gap in terms of oncologists, see, we will never be able to reach that level, or at least it will take some huge efforts to reach that level, what possibly a developed country requirement of an oncologist could be. But then we certainly have technology at our disposal. We have seen in the recent past that how possibly telemedicine or tele-OPD was being used for all of us were consulting doctors, whatever the needs were, and without any personal visits. The cost of a treatment or a cost of a doctor consultation for someone who is sitting in a remote village is like to the extent of less than $1 now. And that is what, if you really see a person traveling from a village to a nearest place where the doctor could be made available, he will lose a day of livelihood. He will also be possibly looking at investing in his own money, and may not get the best of the treatment when he reaches a particular nearest place. But that story is across, whether he is having access for basic healthcare requirements, or maybe even like treatments like cancer, which could be long term. So no, that is where people lose out on early detection, as well as on the cases of treatment when they walk out of the treatment because of these challenging issues. And this is true not just for cancer, but for every other disease that we see. Now, infrastructure should be more like designed with the help of digital inclusive, and not digital as a kind of an overlap. So digital inclusive design is what is the need of the hour, where data becomes the foundation, and technologies which could be cloud, which could be using AI for predicting and triaging, and then looking at how could possibly slowly evolve to a future which could be genetics and precision medicine. Those will take maybe for a country which will become the need for India. However, there are some concerns with regard to privacy of data and some of those issues. We are very careful in presenting and maybe building up frameworks where we believe that ethics or social ethics are the most important part for bringing in responsible use of digital technologies for a kind of a country like resource-hungry country like India. Plus, then also thing is the system should not be designed for someone who is possibly can afford. Digital systems or the infrastructure should be designed for maybe all, bringing in inclusivity to at every level. So that's something which we are looking at, creating more of responsible use of technology, more inclusive technologies, and more sustainable approaches, where we can look at maybe making the systems and also the processes designed with digital inclusivity. So that's something which we are working towards.
Sir, final question, sir. National Digital Health Mission is one of the top priorities of the Government of India and also state governments. So there is a mandate from National Health Authority that, the database to be managed, compiled, and shared with the National Health Authority. So this is between National Health Authority and the National Health Mission at the state government level. So what is the status and readiness of your state, sir?
We are on board with Government of India's National Digital Health Mission. The NIC has some platforms which are being used by state of Chhattisgarh. We don't have a separate any digital platform which we have to integrate we are all we are already following the same sort of platforms. So the Ayushman Bharat platforms are Government of India's platforms. They are there. The drug distribution system platform is there. The hospital OPD IPD platform is there. That is e-hospital. Then HMIS. All these are the platforms. These are the same platforms. So as far as the integration with the NDHM is there, I don't think so. We will have some any issue, and we are going ahead with the whatever the tasks and whatever the action plan which is being proposed by the National Health Authority for NDHM. We are on board and we are going ahead.
Thank you very much talking to us on this panel discussion.
Thank you everyone for going deep into the discussion. Indeed, a very engaging session. Stay tuned for the next set of parallel tracks.